Good morning, good evening, good night, everyone. My name is Renisha Gosling, and today I will be presenting on allocation of healthcare resources, ethical injustice then and now, which will examine how past and present systems influence who receives care and how inequitable allocation can produce ongoing ethical injustice. This presentation examines healthcare resource allocation within the biomedical ethics, specifically how decisions are made when resources are limited. The cases discussed today are hypothetical scenarios used to illustrate ethical tensions. However, they are grounded in historical and socially documented patterns of inequality. Biomedical ethics relies on four guiding principles: autonomy, beneficence, non-maleficence, and justice. These principles will structure my analysis today. I will examine a slavery era case in the United States and a modern case involving a prenatal care for an incarcerated black woman. Together, they demonstrate how healthcare allocation has often been shaped by race, social power, and institutional priorities rather than medical need alone. Just to give a little overview of the first case, this case takes place during slavery in the United States. Two enslaved individuals required medical care. A young male field worker developed a severe infection while an older woman was suffering from a chronic respiratory illness. The younger male received treatment while the older woman received minimal care and later died. This scenario highlights how medical treatment was not distributed equally among those who needed it. To understand this case fully, it is important to consider the healthcare system that existed under slavery. Enslaved individuals were legally classified as property rather than persons and had no recognized autonomy. They could not consent to treatment or refuse medical intervention. Physicians were typically accountable to slaveholders rather than the enslaved individuals themselves, and medical decisions were often made to preserve the economic productivity of enslaved labor. Historical records also show that enslaved individuals were subjected to non-consensual medical experimentation. This context demonstrates how institutional structures directly shape medical decision making and healthcare allocation. And it also showed how the healthcare was used to preserve labor rather than to protect the life of the enslaved individuals. The ethical conflict in this case centers on the unequal allocation of care. Two individuals required medical treatment, yet the younger worker, who was considered economically valuable at that time, received care while the older woman did not. As we can see, allocation was determined by perceived economic worth rather than medical need or equal moral status. As a result, a preventable death occurred due to structural inequality. From a biomedical ethics perspective, all four principles was violated. Autonomy was completely denied because enslaved individuals had no control over the medical decisions that was being made. Beneficence was selectively applied to preserve labor rather than promote patient well-being. Non-maleficence was disregarded completely because preventable harm was tolerated. Justice was absent as care was distributed according to productivity rather than fairness or equality. This basically demonstrates how unjust social systems can override ethical medical practice. Having examined how the four biomedical principles were violated in this case, it is important to consider the broader implications of this type of healthcare allocation. An ethical healthcare system would allocate treatment based on medical need and equal moral worth instead of basically providing the care based on who would work better on the fields. However, slavery as an institution was fundamentally incompatible with the ethical healthcare. One of the long-lasting consequences of this history has been enduring mistrust of healthcare institutions within the Black communities. This mistrust is historically rooted in exploitative and unequal allocation practices. The implications of these historical practices extend far beyond the slavery era. To better understand these implications, it is helpful to consider how patterns of healthcare allocation affecting Black individuals have continued over time. So when we examine healthcare allocations across historical and modern systems, a clear pattern normally emerges. Under slavery, Black individuals were explicitly denied personhood, and medical care was allocated based on economic usefulness rather than clinical need, while in modern systems, legal personhood is recognized. However, institutional structures can still influence whose care is prioritized. The justification has shifted from ownership to administrative efficiency, yet the ethical outcome, delayed or inadequate care, can still occur. These inequities are often structural, embedded within healthcare allocation systems, rather than simply the result of individual prejudice. Considering this historical pattern, we can ask what an ethical allocation decision might have looked like in this situation. An ethical resolution in the slavery era case would require healthcare allocation based solely on medical urgency. Both individuals should have received treatment according to clinical need. This would have upheld the ethical principles of beneficence, nonviolence, and justice. In addition, ethical medical practice would require respect for autonomy, meaning patients would have the ability to participate in decisions about their care. However, under slavery, enslaved individuals were denied legal personhood and therefore had no recognized autonomy. Because of this, a fully ethical medical system was structurally impossible within slavery itself, demonstrating how oppressive institutions can prevent ethical healthcare practices. In a modern equivalent solution, allocation decisions must be guided strictly by clinical risk and medical urgency. Triage protocols should operate independently of race, social status, incarceration, or institutional roles. Independent oversight and equitable access to care are essential safeguards against structural bias. Legal protections now exist, but ethical allocation requires active enforcement to ensure institutional priorities never override patient well-being. While such a solution was impossible within slavery, it helps us consider how ethical healthcare allocation should function in modern systems. To see how these issues can still arise today, we can now examine a modern case involving prenatal healthcare in a correctional setting. For the second case, it involves a 26-year-old Black woman who is 32 weeks pregnant and incarcerated in a state correctional facility. She presents with symptoms consistent with preeclampsia, a potentially life-threatening condition. At the same time, a correctional officer requires hospital evaluation for a possible fracture. Due to staffing shortages and limited transportation, only one hospital transfer is available, and administrators prioritize the officer. The woman later developed severe complications. Although incarcerated individuals have a constitutional right to adequate medical care under the United States Supreme Court precedent. Institutional priorities influence the allocation decision. To better understand this whole situation, it is important to briefly consider the healthcare environment within correctional facilities. For incarcerated individuals, they are fully dependent on the state for healthcare. Limited medical staff and restricted transportation can directly impact access to treatment. Black women in the US also face significantly higher mortality and complication rates compared to other populations. This broader context intensifies the ethical concerns present in this case. The ethical conflict in this scenario mirrors the earlier case. A medical vulnerable patient required urgent care, while an employee also required evaluation. Only one hospital transfer was available. However, the institutional role was prioritized over medical urgency. This raises the ethical question of whether administrative hierarchy should outweigh clinical risk. Henceforth, this situation can again be evaluated using the core principles of biomedical ethics. Although incarceration limits individual autonomy, it does not eliminate the state's ethical obligation to provide adequate medical care. Beneficence was compromised when urgent obstetric evaluation was delayed. The healthcare system failed to prioritize the patient facing the greater medical risk. Non-maleficence was also violated when preventable harm occurred to both mother and child. Justice was also undermined because employment status influenced the healthcare allocation. Unlike slavery, legal protection exists within the modern systems. However, structural priorities still produce unequal outcomes. Given these ethical concerns, it is important to consider possible solutions and the consequences of failing to act ethically. An ethical response would prioritize healthcare allocation strictly according to medical urgency. Correctional facilities should implement clear triad protocols and oversight mechanisms to ensure fair decision making. Failure to provide adequate care can lead to severe health consequences and may also raise constitutional concerns, particularly under the Eighth Amendment standard regarding deliberate indifference to serious medical needs. Ethical healthcare allocation is both moral and legal obligation. So when we compare both cases, a broader pattern in healthcare allocation becomes visible. Both of these cases demonstrate how institutional power can shape healthcare allocation. Under slavery, economic ownership determined access to care. Within the correctional systems, administration priorities can influence healthcare decisions. Although the contexts differ, the ethical failure is similar. Medical need was not the primary determinant of treatment. This comparison leads to the final ethical conclusion of this presentation. Across both historical and modern contexts, healthcare resources were allocated in ways that systematically devalued Black lives. The persistence of unequal allocation demonstrates that ethical failures in medicine are not confined to history. While resource limitations are real, biomedical ethics requires that allocation decisions be guided by justice, beneficence, non-maleficence, and respect for persons. Ethical healthcare allocation requires not only neutral triad systems, but also active recognition of historical injustice to prevent structural bias from shaping modern medical decisions.